Good afternoon, everyone. Thank you for joining us for the webinar today. We're going to get started in just a few minutes to allow for some additional folks to sign on. Good afternoon, everyone. Thank you for joining today's webinar, How to Set Targets to Reduce the Number of People with Serious Mental Illnesses in Jails. Today's webinar is a bit of a deeper dive follow-up to the webinar event we had on September 30th, titled 5 Years of Stepping Up, a Virtual Roundtable. A recording of that will be found in the link on your screen and in the chat box. We are very excited that you all are able to join us today for this webinar. My name is Katie Hebert. I'm a program director at the Council of State Governments Justice Center, having worked on Stepping Up since its inception about 5 years ago. On behalf of the Stepping Up partners, the National Association of Counties, the American Psychiatric Association Foundation, and the CSG Justice Center, we're just very pleased and thrilled that you all are able to participate in the webinar today. Today, we're going to begin with a brief overview of Stepping Up's new call to action, called Step, Measure, Achieve, followed by comments from Sheriff Ian Parkinson, the Sheriff of San Luis Obispo County, California, and Jesse Yates, who's the business analyst for the San Luis Obispo Sheriff's Office. We're going to share their outlook on setting reduction targets. And then we'll hear from my CSG colleague, Emily Rogers, about how counties can really calculate their baselines for the Stepping Up key measures and track their progress over time. Before we jump into that, I just want to mention a few housekeeping items. If you encounter any technical issues during the webinar, you can call WebEx Technical Support. We have included that number in the chat box on your screen. We will also be sending out links and information throughout today's event through that chat box, so please keep an eye on that and familiarize yourself with that feature. This webinar is also being recorded, and a recording will be posted on the Stepping Up website, likely by this time next week. We will have a Q&A session at the end as time allows. Please feel free to type questions into the Q&A panel on the bottom right-hand portion of your screen, and we will try to reply to technical questions as best as we can in real time, and we'll also keep a running list of content-related questions and hold them until the Q&A portion of the webinar. We will be in touch with any questions that we're unable to answer during the webinar. We will be happy to touch base with you afterwards, as well as if there are any follow-up questions that you may have after the webinar. We can always be reached at info@stepuptogether.org and can email you all back with a response. So I'm going to begin the webinar with some comments regarding Step Measure Achieve, but before I do so, I would like to just again introduce our panelists that we're going to have one more time, who we're very thrilled are able to join us today. After my opening comments, we're going to have Sheriff Parkinson from San Luis Obispo County, and followed by the Sheriff, we are going to have Jesse Yates from San Luis Obispo County from the California Sheriff's Office. And then following her comments, last but not least, we have Emily Rogers, who's a Senior Research Associate here at the Council of State Governments Justice Center. Before I move on to some opening comments about Step Measure and Achieve, I want to just quickly highlight a technical assistance opportunity that will be coming up soon. The CSG Justice Center is standing up a technical assistance center under the Justice and Mental Health Collaboration Program from the Bureau of Justice Assistance. This center will offer training, resources, and TA to jurisdictions looking to improve their approaches for people with behavioral health in their criminal justice systems. Resources are going to be available to the field. It's intended to help localities that maybe didn't receive grant funding this time around, but resources are open and available to everybody. The format of the TA could take the form of consultations with staff, connections with subject matter experts and peers, virtual events and meetings, or sort of curated online resources. State, local, and federally recognized tribal governments would be eligible to apply for any opportunities and will be able to request that TA through a form on the CSG website. We're planning to launch this TA center later this fall. There will be some opportunities available specifically to help support some of Stepping Up's goals, including one-on-one and group technical assistance opportunities specific to supporting these Set, Measure, and Achieve efforts that you'll hear about today. So please stay tuned for those updates, which will come via email. We really want to thank everyone who's been involved in Stepping Up these past 5 years. This is just a brief graphic snapshot of the growth of the initiative and how we're just very excited about how it's grown over the past 5 years, really as a result of all of your amazing work. It's really made an impact and has reached far across the country, and we're just very appreciative of everyone being a part of this the past 5 years. The next slide, please. So for those of you who have been involved with Stepping Up, over the past 5 years at any point, we, again, really thank you for your commitment to change for individuals and families and communities and being part of this systems change for years. And as a continuation of your efforts, Stepping Up is moving forward to really support counties in this new call to action called Set, Measure, and Achieve. The details of this new call to action within Stepping Up can be found at stepuptogether.org, including a brief on Set, Measure, and Achieve. We'll put a link to that in the chat box. So you can have access to that as well. And the recording that I mentioned earlier from September 30th Roundtable is on that same page. And as we mentioned, today's webinar is really digging into that brief on Set, Measure, and Achieve, which again is located on stepuptogether.org. Over the past few years, we've all really worked together to understand who is in local justice systems, particularly people with serious mental illnesses and co-occurring substance use disorders. We've identified the high-impact strategies and policies that help us make change, using accurate baseline data to understand this full scope of needs and opportunities that exist. And this call to action in particular builds off of the work that we've done together and really encourages us to take this next step by setting public reduction target or targets. These reduction targets really mirror the 4 key measures of Stepping Up, which are reducing jail bookings, reducing average length of stay, increasing connections to care, and reducing recidivism. along with looking at reducing your average daily population. And while the stepping up measures are focused at the jail, most of the strategies and solutions to reduce prevalence are found outside of, but certainly in very close partnership with the jail, and require that kind of collaboration across systems at all points, from crisis to law enforcement, to the jail, to courts, community supervision, et cetera. And in this way, focusing on the jail and measuring progress is symptomatic, I think, of how well systems are working together overall in a community to ultimately reduce incarceration for people with mental illnesses. So we're recommending setting minimum annual goals of a 5% reduction in average daily jail population, 10% reduction in jail bookings, 5% in average length of stay, 10% increase in post-release connections to care, and a 5% reduction in recidivism. And we know that these are lofty but certainly achievable goals. And to set a reduction target, it is certainly ideal to have a validated screening tool in place that's used universally at booking, as well as a quick follow-up assessment for those who screen positive for potentially having a serious mental illness. However, if you do not currently have this process in place, we would encourage you to still make some reduction goals while in parallel you may be implementing policies and practices that lead to a more accurate depiction of who's in your local jail and what their needs might be. Counties can join Step, Measure, and Achieve by announcing your goals publicly and sharing those goals with Stepping Up by emailing info@stepuptogether.org. We will in turn send you resources such as template press release to announce your participation, and we can always we'd always be happy to recognize you on the Stepping Up website map of participating counties as well. Part of Step, Measure, Achieve is, of course, also measuring and sharing progress. Both the numbers and those really impactful steps that we take on our way to achieving a reduction in prevalence, such as investments in key personnel, implementation of screening tools and evidence-based programs, all of these are measures of the many successes that you all have. Counties are encouraged through Step, Measure, and Achieve, certainly not required, to share progress data with Stepping Up to really help the initiative demonstrate the progress of counties on a national level, as well as to enhance those peer-to-peer connections that we can make. Once you notify Stepping Up that you would want to participate in Step, Measure, and Achieve, we would reach out to you every 12 months for a voluntary data review. And again, sharing data is voluntary, and the information provided would never be shared without any permission. Counties can become a part of Stepping Up, Step, Measure, and Achieve at any point throughout the year. We will be working with all counties to generally track data during the calendar year from January 1 to December 31st, and then we would reach out accordingly to everyone in February of each year to voluntarily report out on progress. We'll work with everyone on this timeline, regardless of when you join Step, Measure, and Achieve, and we'd be happy to reach out individually to discuss further. In addition to the guidance on how to set and measure a reduction goal, which my colleague Emily will be reviewing later, we will also be providing in early 2021 a data dashboard and reporting form that might be helpful to counties that are embarking on this endeavor with us. These tools are not meant as replacements for any technology that counties may already have, but would merely be supplements or support tools that can be used in the absence of other electronic tracking systems. Our goal is to really meet each county where they are with data collection and make that process of tracking progress and potentially voluntarily sharing progress a very easy one, and one that is not burdensome. So any progress that's reported each February, of course, as I mentioned before, would be confidential. And we hope to use the progress again to really continue to highlight the amazing work that you all are doing on a national level, and also make additional connections between counties on successful strategies utilized, and make a lot more of those peer connections. As a result of all this work, we really believe that counties will be even better positioned to identify the successes and opportunities, really allowing for, I think, more targeted and data-driven requests for both local, for local, state, federal, and philanthropic support. Setting a reduction target can also be helpful in amplifying counties' transparency efforts and ensure coordinated planning and progress tracking across these multiple systems that we know are working with you towards these common goals. We know that this year is a bit tricky for data collection and setting baselines and targets due in no small part to COVID-19. However, there are some options that we think might work that we'd be happy to go into detail more one-on-one. Previous year's data, as appropriate, can be used to set baselines. Current baselines, can be set with documenting any potential effects due to COVID-19 and sort of this preparation as a group that numbers can potentially change as policies associated with COVID-19 potentially change. We know from numerical and anecdotal data and conversations with many of you that many county jails are seeing the proportion of people with serious mental illnesses in the jail remain the same or even increase during this time. And so we think this work continues to be really important, perhaps even more so in light of current challenges, as a way to really ensure that people with behavioral health disorders that can be safely served in the community are. So we really appreciate everyone listening to this introduction on Set, Measure, and Achieve. Again, happy to have you all type your questions into the Q&A panel, and we can address those later and get in touch one-on-one. We are going to turn it over to our speakers now, who are going to go into more in-depth on some of the items I talked about and really put in perspective why this is important and why the initiative is kicking off this new call to action around Set, Measure, and Achieve, and followed by following our speakers from San Luis Obispo, we will hear from, again, Emily Rogers from CSG, who's going to talk more through the data aspect in more detail for folks. So I will go ahead and turn it over to Sheriff Parkinson to talk more about what San Luis Obispo is doing and the importance of having a sheriff as a champion on board and data collection to inform policies. Sheriff, I'll turn it over to you.
Thank you. Well, good morning from California. Since I don't know where everybody is, I'm going to leave it at that. And I want to thank you for participating, and thank you for stepping up for inviting me to speak today. So I'm going to cover my topic of how sheriffs can support access to data. In order to do that, I'm going to kind of tell you our story and how we got here. So starting a little bit with me, so prior to running for sheriff, and this is almost 11 years as the sheriff, I spent 27 years of my career at a police department. So I didn't really have a long understanding of jails and really what, as a police department, we were doing with jails by solving our issue on the street by dropping off people for low-level crimes at the jail to solve our problem. So when I came in and learned that, I'd always been a big supporter of dealing with the mentally ill differently, but I didn't realize what was happening in the jails fully because, I wasn't experiencing on a daily basis. So I had, a learning curve of learning what that we were actually holding many more people in jail than our county mental health, or even collectively in the state of California, our mental health hospitals. And as probably many people on this webinar know, dealing with the inmate that has severe mental illness is extremely difficult and extremely time consuming. So I'm going to just tell you our story, but emphasizing that I was a huge proponent of dealing with the mentally ill separately and differently because I saw the impacts that it was causing for cities and the counties. Excuse me, I'll drown the background noise. So our story really started on January 18th of 2017 because I went to this seminar up in Sacramento on stepping up, and I knew nothing about stepping up. I knew it had dealt with the mentally ill, and I really wanted to gain more information and kind of figure out what we could do about it. So on January 18th, I went to the seminar, learned a lot, and I really enjoyed the direction stepping up was going and the purpose behind it. And so I really came back to my county after that presentation, I'd say slightly invigorated to make some change. Now, unbeknownst to me, on January 22nd of 2017, we had a death in our jail of an inmate that had severe mental illness. He had been in and out of jail many, many times, a very violent inmate, and he died of a pulmonary embolism in a restraint chair. And at the time, the jail was made up of really three different entities running the inmate population. We had public health, county public health running the health of the inmate. We had behavioral health running the mental health of the inmate, which is really two separate departments. And then we had the jail that was running really security and other things in the jail, as many jails do. And this was a big problem, and I knew this prior to this happening because I'd experienced huge communication issues and a huge amount of frustration by employees because we had no control over how they did their job. And communication at the time, I think, was very, very poor. So having said that, this death was a result of that poor communication. And as you can imagine, this blew up. So we took some pretty drastic steps early on after this happened. We, as a county, I finally kind of got the ear of the county CAO, who had kind of listened to me before about the problem with the system, but ultimately they weren't moving on it. And I really had no leverage because I didn't even have medical and mental health in our budget. So I couldn't cut off the money and go to somebody else. I couldn't control it. And the pending or the lawsuit that followed this case resulted in a couple things. It was quickly realized that this problem existed. The settlement and the death actually came from medical malpractice because of the decisions made by medical and mental health staff and my staff, quite frankly. But it kind of opened their eyes to, we have a problem. So we brought in a consultant, looked at our system. I had a lot of interaction with the consultant, and ultimately we kind of, as I say, we blew up our system. We started over. As a result, the county gave me full control over medical and mental health. I went out to bid and contract with a jail medical mental health provider to provide the services. But I also at the time was able to get a position called the chief medical officer, and her job is to oversee the care in the jail. And so her job is to, make sure the contract is fulfilled, but also that we are paying attention to anomalies that step up. A number of policy changes as a result of this, but a complete change of direction. And I would say then we really moved into the stepping up phase of understanding what we needed to do and how we needed to proceed. Early on, the community, I'd say, support and involvement was very strong. I formed a panel, a mental health task force, and we began discussing the problems inside and outside of the jail. As you know, the jail only has so much control over opening and closing their doors to let people in. And so we realized that the problem was not only in the jail, but the problem was in the community. And so we identified what the problems were and we worked on solutions and priority of those solutions. And one of the things that we landed on was the need to get involved in stepping up and get buy-in from the county supervisors, and that came fairly easy as a result of this tragic, this unnecessary death, I would say. We learned a lot, and I'll say that early on, we learned the struggle with partnerships and also getting the right people at the table. And as stated in the opening, it's incumbent upon the sheriff to buy into this and understand it. And I think if you can't get that buy-in, then it's going to be a struggle, because I think getting the other departments that are necessary in the collection of data involved, and you don't have that buy-in, it makes it extremely difficult. But the other thing I wanted to mention in that is that it's your personnel in those locations, in those key spots on your program, because as for us, our program has expanded in so many different ways, even outside the jail, that it's kind of constantly requiring involvement and understanding of where we're going and what we're doing. So those were very difficult partnerships early on, particularly in data. In California, we not only have, nationally, we not only have to deal with HIPAA, but we also have to deal with your own state law. And California law is in some ways more restrictive than HIPAA and difficult to share the data that we truly need. Now, if you're in a state that doesn't have that problem, that's a problem that's already solved for you. But, California, because I had been involved in this issue so much earlier than this event, and learned how frustrating it is when we're trying to make a change and we're not getting cooperation. And it's not to highlight and say that our behavioral health department in the county didn't understand it. They have a different mission, and they have restrictions, and sometimes it's a matter of interpretation, and sometimes it's a matter of how you're going to move that forward. So in every one of our key spots that are really centered around stepping up, I know that the people that have volunteered to participate, even in our behavioral health unit in the jail, are deputies that have put in to participate in that role because of their passion for it. And it was somewhat surprising, to be honest, because you don't know who is truly passionate about it until you kind of put out that call and see if they come running. And when they came running, I was really surprised at how many people were truly interested in this population and making a difference. So collecting the data that is absolutely necessary. I think in the opening it was discussed, the assessment tool. Back at the time in 2017, our medical screening and mental health screening was really done by deputies with a checklist. We realized how bad that was, but we weren't getting the funding to change that until this came to pass. And we've since learned the advantages of doing that, because we implemented early on a assessment tool, and really have expanded on that since then, because we know the value not only of understanding what we have in the jail, but actually, transferring to the data collection, which is absolutely necessary. I mean, this is a first step that is clearly, I think, identified when you start going through the process, is that if you don't have the data and you can't track it, it's really hard to take a step forward from that. We have really moved forward with a lot of our collection of data, and I'm going to let Jesse go into that more. Jesse, who is one of those passionate people and is done just an amazing job. And I'll just say this: we went from probably one of the California counties, which I think most were in or still in this position, that they're a second away from a tragedy in a lawsuit. And even without a tragedy, we all know that there's law firms that are going around suing jails for conditions. And the state of California prison system was sued federally and lost, or at least conceded, and it's really changed the system. But we went from that to becoming an innovator county with stepping up, and largely because of Jesse's tireless work on this. So I'll say this, that you have to convince, your sheriff and the people involved that they have to believe in the success of this. And ultimately, it's, two things are going to happen. Number one, it's going to be the best for the individual inmate, getting them in a location and treatment and or staying out of jail, which is ultimately the goal. And also it's going to help you move forward and really alleviating some people that are in jail that don't belong in jail, that are extremely costly and time consuming for your jail. So I'll kind of end with this, that it's this is the first step in building a successful program. And I started to go here, and I think I just said it, but I'll repeat it just because Jesse's going to present after me, that as an innovator county, I'm super proud of the work our people have done, and I'm super proud of the fact that our community has understood that we have put so much work into this, that, as a matter of fact, with our overall program and the direction we've gone, some of our neighboring counties, some of which are even larger than we are, have come to our jail to see what we're doing and have copied our model because of its early successes, but also because we've done a lot of the work for them. We've kind of gone down that road, and so they've been able to see what we've been doing and see the success in it. So it's been good. And I'll say that if you're having trouble convincing your sheriff that this is what they need to do, I would do two things. One, I'd keep in mind that we're all a tragedy, or one second away from a tragedy. Use others' failures and successes in convincing your sheriff that this is worthwhile and that it will really change what you're doing. We know we have a growing national problem. I think early on it was also mentioned that during COVID it's a difficult time with data, and that we've seen changes in our numbers as a result of the people in custody. I can tell you in California right now, they're accepting very few inmates from county jail that have been sentenced to prison because of COVID. And as a result, about a quarter of our inmates have already been sentenced to prison, which makes it even more difficult to provide, treatment and resources. And so I'll just say that with Jesse going into the data is the most important thing to get going. And even during COVID, you can lay all the foundations of your partnerships that are going to be required to do this, your mental health, district attorney, courts, IT, all those people. This is the time that you might have to work on that, to get that in line, to ultimately collect your data that you will need. So with that, I'm going to end and pass it on, and then obviously be available for questions.
Great. Thank you. Thank you, Sheriff. Just wanted to quickly say, we couldn't agree more that having sheriff support is essential for these, for stepping up and embarking on these efforts. And so very much appreciate you sharing your story and your work, and thank you very much for your leadership on this. And we'll go ahead and turn it over to Jesse to talk a little bit, go into a little bit more detail about some of the data pieces that you were mentioning. Jesse, want to go ahead?
Yes, thank you, Katie, and thank you for everybody who is on the call today. Like I said, I am Jessie Yates with San Luis Obispo County Sheriff's Office. I'm a business analyst, and I work full-time on Stepping Up. And I know that's kind of unique for some counties to have personnel who works full-time, and so we are blessed to have that. And with the Sheriff's support, that I'm able to do that full-time. We have committed to set, measure, and achieve. A disclaimer I was asked to mention is that we are presenting to the Board of Supervisors in about a week to get, just the final sign-off on our numbers, but we are confident to be able to approve our strategic plan and go along with our future goals, our target reduction goals. What we have learned here in SLO County, that's what we call it locally, SLO County, is that the backbone to building a strong plan and being able to meet the set, measure, achieve call to action is the data behind it all. If you don't have data, then it is going to be very difficult to set your goals, not knowing where you're starting from or where you're going to be able to go. And then measuring them, that's going to be impossible. So being able to collect data and share data is really the most important part and the first step towards set, measure, and achieve. And then if you could go to my first slide. So we got started by first identifying the population. It seems like a simple thing, but a lot of times different departments really don't have a focus of, what they say is an SMI might be a little bit different than someone else. We knew that we wanted to focus on the individuals that were suffering specifically from severe mental illness. So we began by meeting with the county behavioral health department, who does a lot of the outpatient once they're released, and got their definition of SMI. Here in SLO County, as the sheriff mentioned, we have contracted with a jail medical provider to provide the medical and mental health services for the jail. So then I took that definition and met with their leadership and got them to agree on the definition and how they would define the people in the jail to match that definition, which it goes along with the DSM-5 definition, for those of you who are wondering. And once we got that, I brought it to our Stepping Up Steering Committee, and they approved it that would be our countywide definition for SMI. We did this so that we could collaboratively work on the same population and have a directed individuals to start identifying and collecting that data on. Within our jail, we have implemented a validated screening tool at booking. Again, that's the Brief Jail Mental Health Screen. We like the Brief Jail Mental Health Screen because first off, like I said, it's a validated screening tool. Second, even though we do have a nurse that performs that screening at intake, that can be administered by anyone. So if you don't have the funding like we do now to have a nurse at screening, anyone can administer the Brief Jail Mental Health Screen. They don't have to be a medical professional. If that screen's positive, then we have a psych tech further screen that person in order to see if they have SMI and need to be seen by a psychiatrist. For individuals who are identified as being SMI, we have a flag in our medical electronic system for those individuals that we created so that we could more easily track them, and is that flag that really begin to help us collect all of this data. Sharing this information is very important as well. We have a bi-weekly jail to community meetings that we're able to confidentially discuss these individuals in order to make sure that the probation department has the correct caseload for their probation officers that are assigned to the special population. The behavioral health department also meets with our mental health manager to get referrals on who will be appropriate for mental health diversion court and the like. We were able to do a lot of this by getting a signed memorandum of understanding in our county, and we had behavioral health, probation, the courts, the jail, our county administrative officers, and our district attorney all sign on to that MOU. Next, what you have to know is what indicators you're going to be tracking. Here we track many different attributes within our SMI population. So we track their age, their gender, their race. We track whether or not they're on supervision or probation, depending on where you are, I might call it something different, or not. If they're pending or if they're sentenced already, we track their housing location. We track the number of prior bookings. This way it's a lot easier to identify those high utilizers and who keeps coming back into the jail. Within those bookings, we also track which of them were technical violations, and if they weren't a technical violation, how many of them are new charges, and then if they're a felony or misdemeanor. We track their average length of stay, and we also track their release dates. One big thing also because of COVID, now we're tracking whether or not they're sentenced to county jail or to California state prison system. Because again, our population used to be very small in that. Now it has grown, and it's over 20% of our SMI population is sentenced to state prison, but now we are in charge of them in our jail and need to provide those services for them. We track whether or not that they're co-occurring and if they're incompetent to stand trial. Once we get all of those indicators for our SMI population, we compare it to people with non-SMI. So we really collect the data for our entire jail population. And so can you go to slide 2? Thank you. And so to further identify the population, besides the brief jail mental health screen, and to further grow that population, it's always good to look at the medications that they've been taking when they come in. Also communicate to your jail staff to report any signs of SMI to the psych tech or the nurses or the other mental health staff. A lot of times your custody deputies, they're going to be your front line, and they're going to say, hey, this person is something not right here, and we're going to need some help. And so, because sometimes people come in and don't have their medications, so if you let them know, hey, it's okay to communicate back to your mental health staff to come check this person, please do so. In our collaborative meetings, make sure that if someone's discussed to check in your system for the flag, so say probation has them on their caseload, make sure that you can cross-reference with your load as well. So having a dedicated person like myself that tracks this makes it easier. So again, that's really good if you can encourage your leadership to have somebody who can track that. To have that person keep a list of the SMI between the different departments and have access to merge them within your jail records. I work within the IT department, so that makes it a little bit easier for me. If you do not have a screening intake, or even if you do, it is acceptable to ask them if they have a mental illness and take that self-report and get them accessed further by that mental health professional within the jail. We also further identify individuals who may or may not have self-reported or screened about when they're deemed incompetent to stand trial. And then can you go to the next slide? Okay, and so access to data. If you do not have a contracted provider, then having access to the data should be fairly simple because it would be within your county's network. And also identifying your staff who works on stepping up within your organization and letting them know, hey, these are the people that are going to need access to that data. If you do not use a contracted, or if you do use a contracted medical provider like we do, then it's not quite as easy in the beginning. In our contract with our provider, we have specifically stated that they need to provide us with the access to that data. So if your contracted provider will not agree to that, then go to your leadership team and see if, a lot of times it's once a year, that you can negotiate a little changes in your contract because it's not like a huge thing. Have the leadership get involved and work on adding it so to make sure that at any time if you need access to that data, you're going to get it. Because again, if you don't know who has SMI in your jail, you're not going to be able to set target reduction goals or even know how many resources you need in order to help them. The process for tracking the data. First, you have to set up how you're going to do that. Decide how often you're going to run the numbers for the data that you're collecting. We run this just about weekly, especially with COVID, because we see a lot of movement and changes in our population. Here in California, laws seem to change more often than the sun comes up and goes down. And so we really have to make sure we have our finger on the pulse and that we're watching that. So that's why we look at that weekly. We do track this in Excel, so most people have access to that, just a basic tracking system in there. You should have a definition and understanding for each data point that you're collecting, and Emily's going to discuss a little bit later in the presentation on exactly how to do that. Identify what you will be tracking. For Set, Measure, and Achieve, specifically, we track who screens positive on the brief jail mental health screen at booking. We track the average daily population of both SMI and non-SMI. We track their average length of stay. We track the number of appointments set at discharge for connections to those treatments at release. And again, how many times they were booked into the jail, and for those, which ones were the new offenses and technical violations. And so for set, measure, achieve, even though we collect more than that, that's what we're focusing on. Setting your baselines, once you've been able to identify the population, you'll need to compare the data of your SMI population to your non-SMI population, like I was saying. Make sure that you're comparing apples to apples. I know early on in the process, we had a lot of questions of who to include or who not to include in the data. And what I mean by that is we have individuals who are housed off-site. So, for example, because of COVID, we have people who are home detention who are located at home or even at a state hospital. We chose to include in our target numbers only the individuals who are housed here at the county jail. And so if they are off-site, we do still track them, but they're not included in our baseline numbers. We can really only affect change for the individuals that we have access to. So that is why we choose to focus on the population here on site. We do have a jail-based competency treatment program within our jail. So as of late, we've been restoring most of our patients who were incompetent to stand trial. So we're not discounting those people from any of our numbers. Those people are counted as well, even though they are technically in a state program, competency program. They're still on site, so we keep them in our numbers. That's actually helped us a lot with COVID because there's a long wait list to be transferred to the Department of State Hospitals, and so that's been something that's helped us to meet a lot of our goals. In setting these baselines, again, it's very important to make sure that you know who you're including and don't include in the beginning site and release sometimes in your numbers. You don't realize, but they're coming, they're not even ever getting booked into the jail. So make sure you work with your technical team to make sure you're only including people who are actually booked and put into the jail. If they're booked and released and you're counting them, it's really going to skew your numbers. Next, setting your target reduction goals. In order to really set reduction goals that are within reach for your jurisdictions, it's important to have those agreed upon definitions. For example, recidivism. A lot of times there's a lot of discussion between probation or the jail or another department of what recidivism is. So make sure you have a very clear and concise definition of what you're looking at to make sure that you understand the numbers. And so doing a deep dive into your current process is really what we started doing. And so within what we did for our county was we did a system analysis where we did a system mapping, a process analysis, and most importantly, within that, we identified gaps and needs within our system. Once you do that, you can begin to write your strategic plan and identify funding, whether that be from grants, community partners, or even identifying staff that's already in place that can assist to meet your goals. We did receive the Justice and Mental Health Collaboration Program grant, and in that, there was a planning and implementation guide outline that we were able to follow, which greatly helps to give you some direction in how to put together that information, because I know when people say system mapping and process analysis, it can sound like a daunting task. But the Stepping Up website also does have a planning and implementation outline, and I strongly encourage you to check that out if you have not. It's something that's going to just really help to direct you in what kind of things you need to look at and how to figure that out. So we really appreciate that planning and implementation guide. Once we had our baseline goals, agreed on definitions, and an idea of what resources or funds will be available, we were able to set our reduction targets, which I'm going to be going through each target in a moment for here in Flow County. And just to mention before we look at that, I wanted to mention that we currently are also working on a dashboard that will help us to further share the data and measure our progress. Eunice did mention at the beginning of the call that they will have a template for tracking your progress, and I encourage you to use that once it's released. And so I believe it's in Excel, and it's something that you can just put in your numbers, and you'll be able to have some clear pictures and graphs of how to measure your data. So the next slide. Okay, so our baseline data and goals. So for set, measure, and achieve, for measure 1, reduce the number of people who have mental illnesses booked into the jail. we are looking, I know with Step Measure Achieved, they're asking for 5% on this one. We said for our bookings, the 2% reduction annually for those who screen positive on the brief jail mental health screen, with a long-term goal of positive screens at booking making up no more than 22% of all bookings on average. We said 22% because a lot of times on that brief jail mental health screen, they might screen positive, but that doesn't mean they have a severe mental illness. Our average population right now is about 22% of people with severe mental illness, and so we're hoping for that to go down, obviously to about 10 to 12%. So that would mean the other 10% screening positive might have a mental health illness, but they're not a severe mental health illness. So it's kind of like, okay, about 10% of the jail severe, 10% with a mental health illness. So that's how we got to about 22%. For our baseline data for our calendar year of 2019, on average, 84% of all of our bookings received the brief jail mental health screen, and about 28% of those were positive. So it'll take us about 3 years to get down to 22% with a 2% reduction each year. Our average daily population, we're looking to do the guideline that was set by Stepping Up, a 5% reduction annually in our average daily population of those with the SMI in the jail, with a long-term goal of SMI inmates making up no more than 10 to 12% of our average daily population. We do have people who obviously are incompetent to stand trial, and so those are always going to be coming into the jail. So we feel that 10 to 12% is a very obtainable goal, but it's going to take some work to get there. Our baseline data in 2019, individuals with SMI actually only made up about 12% of our population, which was nice. But that's also when we had a lot more individuals in the jail. Here in California, we still go by the bail system. And so in July of 2020, or before July of 2020, we implemented changes due to COVID. And so we released a lot of the jail population, and we're thinking that this population we're looking at now is going to be about what we're looking at. So that's why our baseline is set at 22. We do not feel that the jail is going to go back to the same jail before COVID, and so that's why we are using our post-COVID numbers for the baseline data here. And again, like I mentioned earlier, we do not include inmates that are housed at locations other than the jail, like people on home detention. On the next slide. Reduce the length of stay for, in jail for people with mental illness. Average length of stay, we're looking to reduce the guideline of 5% annually in the average length of stay of people with SMI. Our long-term goal would that to be the average length of stay for the SMI to be equal with that of people without SMI. And so we do know we are going to have those individuals that are incompetent to stand trial, but again, having a jail-based compensatory treatment program here on site has been a huge help in being able to lower that number and take away that wait time for a state facility. Right now, SMI is about 178 days, and the average length of stay within that population without SMI is about 160 days. Next slide. For our, I think, there we go. Third goal, increase the percentage of people with mental illness connected to treatment in the community upon release from jail. In our first year, we're looking to hit 60% of people with a 20% increase in the second and third years for individuals with SMI for post-release behavioral health treatment. And for those with an assessed need for treatment who do not refuse. And so our goal is for any person who's not refusing discharge planning, we want every single one to have an appointment at discharge. We know it might sound like a lofty goal, but it's definitely something that is obtainable, and I believe is the right thing to do to really not just release them without having any direction whatsoever, especially when they're asking for that. And so right now we track this in Excel. This is a little bit more difficult to track with automation, and so this is something that we manually track at discharge. So we have a list of everybody getting discharged as SMI, and we literally manually track, like, yes, they got an appointment, or no, they did not. And if they did not, we're going to be looking at why that happened. Okay, and the next slide. So for our fourth goal of reducing recidivism rates for individuals with mental illness, we look at rebooking. So we're not looking at recidivism per se, because a lot of times somebody might be booked into the jail, they're pending, they're released, they come back in on another charge, they're pending again. Because really what we're looking at is how many times are people with severe mental illness being brought to our door and booked into our jail. Whether or not they were found guilty or sentenced, that's not something that we felt was pertinent. So that's where we're looking at the actual rebooking. How many times did they come and sit there? We want a 5% reduction annually with a long-term goal, again, of people with SMI being brought to the jail the same amount as individuals that do not have SMI. And this is just a chart that shows SMI, and then CSMSA, that's co-occurring severe mental illness, substance abuse, and then non-SMI. So again, we do also track if they have a co-occurring or not. And the next slide. Again, like I was saying, we track our technical violations. We want to see how many times people are on probation who are being brought, who do have SMI or who don't. And again, we want to match that. So we don't want people who have SMI to be criminalized within the probation department either, and brought in more often than people that don't. They need to understand what they can or cannot do in the community to not be brought back on a technical violation. And the next slide, which I believe is my last slide, new charges. Again, 5% reduction in that until we meet the same as the non-SMI. And so as far as that goes, those are all my slides. I will be available for questions and answers at the end. And again, having, like the sheriff was saying, having your leadership on board is something that is very, very important, and one of our priorities here is making sure that we communicate with the leaders of all the departments and the stakeholders involved to make sure that they know what our work is, what we're doing, and how we're trying to get there, which the communication is key and the support is key. So thank you very much for having me, and I will turn it back to you.
Great. Thank you so much, Jesse. It was really thrilled to have you all be part of Set, Measure, Achieve, and really helpful to hear the details about how you're collecting data, how often you're collecting it, how you ensure the data you collect are quality, based on the brief jail mental health screen and other data and definitions, et cetera, and how you sort of bring all of that together for tracking and making these goals. So really helpful to hear that, and thank you for sharing that. I think we'll go ahead and turn it to Emily Rogers, who's going to talk a little bit more. We see some questions coming in about how these are tracked, what are the goals again, et cetera. So we will, of course, in the chat box again, put a link to the brief, the Set, Measure, and Achieve brief, which has what Emily is going to be talking about in detail. It's also on stepuptogether.org website. But I'll go ahead and turn it over to Emily to dig in further into the measures and targets for Set, Measure, and Achieve. Emily?
Thanks, Katie. Jesse and Sheriff Parkinson gave a really great overview of how counties can use data to help their SMI population and really understand it and do some effective planning. And now I'm going to talk about how to measure your progress using the guidance that's in the Set, Measure, Achieve brief. And if you have seen it or if you have it open in front of you, the guidance that I'm going to be going over is located on page 3. I'm going to briefly talk about the measures. Katie mentioned them at the beginning of the presentation, but I'm just going to go over them for your information and to jog your memory a little bit. The first one is average daily population, and this measure is used to show the prevalence of people with SMI in your jail. And then there are the 4 key measures that are jail bookings or admissions, average length of stay, which we abbreviate as ALOS, connections to care, and recidivism. Could you go to the next slide, please?
Emily, this is Katie. Can I also, if you could also just get a little closer to the microphone, that would be great.
Oh, okay. I'm sorry. Thank you.
Yep.
Are you able to hear me better?
Yes, I believe that is a little bit better.
Okay, great. Before you produce your measures, there are a few questions that you might want to be able to answer, and I'll just go over some of the ones that come to mind for me. For example, when did your county start tracking SMI? You need to have been consistently tracking SMI for a little while, just because you don't want differences in your measures to be reflecting the fact that you're getting better at finding people with SMI. The second thing you will want to keep track of is when new policies were implemented. So if you have new policies that are going to hopefully reduce the population of folks with SMI, you want to be able to note them, because that will be helpful in understanding your data when you start to review it. And finally, you need to identify the time periods that you're going to use as your baseline period and your reporting period. And by reporting period, I'm just talking about the period that you're going to be looking for producing those reduction measures that we hope to see. Once you've selected your baseline period, you'll want to select your baseline period after your SMI data collection was started, but before your efforts to reduce the number of people with SMI in jail. And that's sort of an ideal, and maybe not everybody is going to be able to achieve that. I think that we can probably work with different systems who are on different timelines. But if we want to measure the difference between what the SMI population looks like prior to starting to try to make reduction targets and after those targets are begun, you'll hopefully have your baseline period, the change that happens, and then be able to measure the reductions that follow. Next slide, please. When you're preparing your data for analysis, you'll need two populations. So the first is all of your bookings that happen in the time period of interest, and the second is all of the releases that happen. All of the measures that are included in the guidance document come from either the bookings that happen during a period or the releases that happen. You'll want to be able to identify true bookings and releases. So if there are movements that your system tracks that don't actually indicate a person entering or exit the jail, you want to be able to account for those. And Jesse spoke a little bit about like the cite and release cases or people in home detention. So if there are situations where a person is not truly booked or truly released, you want to be able to exclude them in your data. So you either need to flag those cases or you need to exclude them from your data so that you're not counting things that are not true bookings and releases. You may need to merge continuous lengths of stay. So if you have more than one record for a person because of a movement, you want to be able to capture their entire length of stay in that average length of stay measure. And then finally, you may need to standardize demographic variables into categories that are useful for analysis, such as different racial or ethnic groups. If you have some that are very small, in order to protect people's privacy or to help with your analysis, you may need to collapse some of those categories together. For age, since everybody will have their own age, you'll want to have groups. You want to be able to group people into different categories by age. So there are some considerations. Jesse mentioned wanting to clearly define all of the indicators that you're using and have clear definitions for your data. So I would say this point goes right along with what she said there. When you're standardizing your demographic information, you want to clearly define who's in what group. Next slide, please. Once you have your bookings and releases files, you'll need to incorporate SMI information into those files. So maybe some systems might have it already in the jail case management system, but in some locations, the SMI information is tracked on Excel spreadsheets or in a separate database. You may be getting the information from a provider. Some types of information that you may want to incorporate into your bookings and releases files would be the screening, such as the date the screening happened, what the result of the screening was, whether it was a positive screening or if it was not positive. If an assessment took place, again, you'd want to know the date of that assessment and the result of the assessment. You may consider having a flag that indicates there's some kind of diagnosis or that the person is part of how your county is defining the SMI population. And then finally, you'll want to have information about connections to care, and data points that you may want to track there might be the date that a referral was made, whether a person showed up, what agency the person was referred to. So there are a number of data points that you can use. Next slide, please. So I'm going to start going through the measures at this point. So the first two measures, and I'm going to do them out of order. So in the guidance document, you'll see them listed as starting with the average daily population, but I'm actually going to skip ahead to the two measures that come from the bookings file. And the first measure is just the number of bookings or admissions to the jail. And our guidance is that we don't count turnaround admissions, which are considered things such as trips to court or the hospital. If it's not something where they are exiting to the community, we don't necessarily want to count that. And then the second measure that we are tracking from our bookings file is our rebookings. And so this is a little bit different than some people might be thinking of, as recidivism is usually, or is sometimes defined, where you're looking forward in time to see what happens to a person after they leave a facility. For our recidivism measure, which really ties back into how Jesse discussed it very nicely, we're looking at rebookings. And for rebookings, we are going to look at the number of people admitted who had a prior jail admission in your county jail in the past year out of the total number of admissions that took place during the reporting year. And that will give us a sense of how frequently people are coming back to your jail. And so it is considered one of our measures of recidivism and is one that's particularly useful when you're looking at a jail population. Next slide, please. Thank you. So the next two measures I'm going to talk about are from the number of releases that we had during a time period. And the first measure that I'm going to mention is the average length of stay. And for average length of stay, we are going to add the total length of stay of everybody who was released during that time period and divide that by the number of release events that occurred during the time period, and that will give us the average. When we calculate length of stay for each record, we are going to take the release date and subtract the booking date and add 1. And the reason that we do that is so that people who come in and exit on the same day, they're given a length of stay, it appears as 1 day rather than 0. And then the other measure that comes from the release population is those connections to care. Connections to care is going to be the number of those identified as SMI who are released and referred to a community-based behavioral health treatment at the time of release during that reporting period. And we'll take that as a percentage of the number of people with SMI who were released during the reporting period. I think the important thing to think about when we're defining the measure of connections to care is that the base population would not be all releases, but only those who had been identified as having SMI. Next slide, please. The final measure that I'm going to talk about today is going to be the average daily population. And this measure can be calculated using the booking information from bookings and information from releases. And so to calculate average daily population, we'll multiply the number of bookings that occurred during the reporting period times the average length of stay during the reporting period and divide it by the number of days in the reporting period. And this is a way to calculate average daily population that is accessible using the measures that you're already developing for the rest of your report. But it is important to consider a couple of things. This calculation would only really work if the number of people who were booked is pretty similar to those released. So it tends to work well for a jail population because folks tend to come in and leave pretty quickly. This measure will work if the average length of stay is relatively short. If your average length of stay was multiple years, this wouldn't work. But for a jail population, this is a good way to calculate average daily population that's using information that you probably already have. Next slide, please. So finally, I want to talk a little bit about how you set and measure your reduction targets. And in the guidance document, there are some guidelines that will take you through sort of what you would think would be the minimum reductions that we would recommend you trying to achieve through this process. You can use your baseline data that you collect and reasonable assumptions that you make about the reductions in order to set the targets. And we are going to express those reduction targets with percent change. And to calculate percent change in this context, we're just taking the target measure that you have, which is your end goal, and you would subtract your baseline measure and divide by your baseline measure. It's important to remember that your baseline period and your current period would need to be equal time periods if you're going to be doing this type of calculation, because as Jesse mentioned earlier in the presentation, it's part of being able to compare apples to apples. But the way that you can use this information to set your targets is really by thinking about what types of changes might be made to the four key measures. So how much would it be reasonable to expect to be able to reduce your bookings, to be able to reduce your length of stay? How many more connections to community-based care is it reasonable for you to be able to make? And once you have a good estimate of what those numbers might come out to, you can calculate the percent change that you hope to achieve. This is just a way, if you want to go even beyond the minimum targets that are set in the guidelines. If you want to use the minimum targets that are in the guidelines, those are suggested percent reductions that are available to you that we think are achievable and realistic. But you could always try to do more if you think that it's realistic that you could have a higher, greater decreases. I think that was my last slide.
Okay, great. Thank you so much, Emily. Really helpful to go through all of the different measures. Again, if folks haven't seen this, the document that we have been talking about is located, the link to that is located in the chat box. So hopefully you all have access to that. If you haven't been able to, please reach out and we're happy to provide that directly. So I'd like to start with the Q&A portion. We have about 15 minutes. There have been a lot of questions coming in. Jesse, if it's okay, I'm going to start with you.
Okay.
We have a few questions. I will, thinking of how I can put these together into one. So there were some questions around how you are distinguishing serious mental illness from your positive brief jail mental health screen. So for example, with regards to connections to treatment, or are you treating a positive screen as an indicator of SMI for simplicity's sake? So that was a question as to if you're using the brief jail mental health screen as an indicator for SMI, or where that lies in the process of how you are counting folks as having SMI.
Okay, so for the brief jail mental health screen, if that is a positive, what it does is it sends a little task that goes to our mental health department, and a psych tech will go, jail side and do a further assessment. So no, we do not use, to answer the question specifically, we do not use that as an indicator for SMI. We use that that promotes a more in-depth screening tool that then determines whether or not they are SMI or not. So that's just our initial, like, hey, this person might have SMI, so go. We usually do it, it's within 2 weeks, but it's usually performed a lot quicker than that from when they're booked into the jail. But no, we do not use that as an indicator and to flag everybody for SMI.
Great, thank you. And then another question is how long you tracked your baseline data for. So I think the question is, what was the length of time that you used for data collection in order to establish your baseline? Our baseline data that we're using now is post-COVID. We started collecting it, having a clear connection last December, and we just set our baseline this last July. And so really, we've been collecting data for 8 months, and that's how we were able to see the anomalies and really how COVID affected us in that population. So it was 8 months before we determined these baselines. But if it wasn't for COVID, it would have been earlier than that. So we had baselines, and we actually changed them post-COVID numbers, and as well as the changes within the jail, going from a system where we had bail to zero bail, and then now being voted on here in about 12 days as no bail system here in California. Great, thank you. And question for the sheriff. Sheriff Parkinson, you mentioned during your comments that you really kind of blew up the system, so to speak, and wanted to do things very differently. And the question that came in was, sort of how you were able to accomplish those things. Was it as a result of being the sheriff, so having sort of that authority and folks listening to you, was that sort of the helpful piece of it, or did you find that other pieces like establishing other partnerships or so on were essential for being able to make the changes that you were seeking to make?
I'd say that it certainly helps to be the sheriff and to have some influence over where we're going. But I think what was equally helpful is the fact that forming the mental health task force, which was largely made up of people in the community that either had they were part of NAMI or they're part of mental health privately, publicly, had some role in the community of dealing with having somebody with mental illness, and them coming together with their ideas. And I think my approach and strategy is that A, identify the problems, and then B, identify solutions. And that's a pretty powerful message when you have 24 people in your community. And certainly I had some custody personnel in that forum that worked with them because they had questions of how we did things, and there's a lot of misinformation out there. So working through that, but I think ultimately that probably was equally powerful to the tragedy we had, because it's hard to ignore when people are telling you that that system is broken and that they're coming up with solutions of how to fix it. So I used that, and we actually rolled that committee into our Stepping Up committee and renamed it, because we had already done so much work on that before we really went full speed ahead with Stepping Up. So I think getting those groups together are fairly easy to do, because what I found is that everybody wanted to participate because they recognized the system as broke and they needed to make changes. And there was a lot of frustration and a lot of education and a lot of coming together. And it culminated into a very powerful message to the people, in California's case, where the Board of Supervisors really their control over the sheriff is financially, and they make the financial decisions. And some of this is going to require financial decisions. So when they're faced with that, it's hard not to listen. And even for, I would say, even for a sheriff to hear all that, if your sheriff's kind of on the fence, and I'm not saying go behind their back, so please don't take that. But there's a lot of law enforcement executives, that hear the problem and they understand the problem, but are not necessarily passionate about making a change. And when they hear from a collective group, and by the way, I didn't sit on the group purposely. I appointed a chair because if the discussions about the jail were critical of me as the department head or the department, I wanted that spoken freely in the meetings. And so I simply got their opinion as to what the problem is, what the solutions are, and ultimately I put it back to them and said, please prioritize it for me. Tell me what are the in order that we have to do right away. And so it really gave me an opportunity to not only present that for the funding requests that we did, but also they clearly gave me the ability to approach the county and say, this needs to be, I will be happy to take full responsibility, but I need control to do that. And I need to be able to monitor and move forward. And that, I would say, probably was one of the strongest things that I put together to help make significant change.
Great. Thank you. Thank you very much. This question, I think, either for the sheriff or Jesse. So there was a question about the new medical provider that you all selected, and some questions about what was important to you all in making that decision. Sort of what were some criteria or conversations that happened around that selection that you felt were helpful in finding a new medical provider that maybe was more of a fit with your the goals and the direction that you were headed in?
Well, I'll start with it, and then Jessie can chime in because she has a connection as well. So for me, obviously, we have to go through a RFP process and find out who's out there and who's available. We did a lot of. Let me back up. I had mentioned my chief medical officer before. When the county agreed that we were going to make this change and they were going to shift that to me, I said the first thing I need to do is hire a chief medical officer. I need this doctor to be involved in this from the very beginning of the process. And just to be clear, that chief medical officer does not see inmates in jail. We have, through our provider, they have doctors that see the inmates. She is oversight to the contract and oversight to inmate care. So when we have a inmate with significant medical issues, she's a direct report to me, which is fairly unusual, but something that I really wanted. So when she had an inmate that we really needed to get out or get into some other treatment, she could bring that to me. So she set out with a group, and they actually went and vetted the providers that are out there. And in California, there's not a lot. But interestingly, what we found out is even with providers, if you can buy a top-notch plan, but if you don't add the a la carte items that you want, they're not going to get done. So we really examined different jails where the providers were to find out what were they doing and how much they were doing. And then we kind of decided this is what we want. This is the system we want. And then the other thing she did, and it kind of goes to what Jesse said earlier, which I think is important. If you need the data, you have to spell that out. And I remember getting a weekend call from my chief medical officer as she was working on the contract after we had selected. And she was going through and just really worried because she'd never done anything like this before. And so we were talking it through. And I said, well, you've seen sample contracts from other agencies. And she said, yes, I got them from those agencies. And I said, so how does ours compare to theirs? And she says it's about 10 times longer. And I said, so 10 times longer as in more detail? And she says, absolutely. And I said, then you're absolutely going down the right trail. I mean, we want as much specific information there as possible, including what Jesse talked about, that if you want data, you tell them that. And they're out there and they're hungry to get the business and to move forward in signing a contract. So we had very little resistance on the things that we absolutely demanded in the contract. And as Jesse said, if you have a current contract and that's not included, do an addendum to the contract. And I know with our provider, which is a company called WellPath, they had been everywhere. And I'll just say, one other thing on that is that there is no perfect provider out there. I think the more detail that you ask for in your contract and hold them to, the better off you're going to be, because they will do it. And yeah, sometimes it's for a cost, but don't start off, hunting and putting something together that's leaving out things that are going to really in the long run help you get the data that you need, because as we discussed, getting data is difficult. I did get a question regarding, how to pull all these together, and Jesse can certainly go into more detail, but the bottom line is because the confidentiality and everybody kind of holding their own data, we had to establish this system, and we called it Switzerland because the people on it getting the data were vetted and cleared either to look at the criminal stuff, the mental health stuff, and they were kind of the eyes on this. And so we had to go to a system that was really unusual, but allowed us to get the information. And our medical provider was a provider of that information that we absolutely needed. And we knew that going in to our contract with them. So we really detailed it clearly in our contract.
Right. Jesse, is there anything that you'd want to add to that?
No, I think that was good.
Great. Emily, a question for you, and this might be the last question in terms of the time for today, but I will say that for the other questions that came in, we have been taking stock of them and we'll reach out for individual answers following the webinar. But Emily, there was a question about, you mentioned during your presentation that people were counted as being rebooked if they've been in the jail prior. And would you also include anyone who had come back to the jail after leaving a state prison? So I'm curious if you can address that.
I think that's a great question because it speaks to the importance of having a really clear definition of all of these measures. And people may be measuring recidivism in different ways in meetings, and there are often good reasons for those differences. For our purposes, we focus specifically on jail bookings, so returning to the same county facility. And we're limiting the time period we're looking back to 1 year, so that that helps us compare people equally, so that we're not looking back if some person has a 30-year criminal history and another person is younger and they have a shorter history. We're going to only limit it to looking back in the 1 year period. That way we can have a more uniform measure. So for our purposes, for this particular initiative, we're defining it as bookings in your local jail in the past year, which is not to say you can't have, for other purposes, a different measure for recidivism. I think the point that I would just want to drive home is that it needs to be clearly defined, and if you can make it clear what you're measuring when you're measuring recidivism so that we know what you're doing, that would just be, I think having that definition available kind of front and center is key.
Great. Thank you, Emily. If we can go to the last slide, that would be great. As I mentioned, for folks that that we didn't get in touch with, please feel free to reach out. We will also be proactively reaching out to you all with some answers to those questions. You can reach us at the contact information you see in front of you. We're also available at info@stepuptogether.org that you can see on the bottom there for any questions and follow-up. We really appreciate everyone for joining us today. Thank you very much to Sheriff Parkinson and Jesse for your leadership and work in San Luis Obispo and being an innovator county, and Emily for crafting that brief that you all are reading and explaining in further detail today. Really appreciate everyone being on the webinar with us. We hope to continue this conversation as we're moving forward with Set, Measure, and Achieve. So a lot more to come. And we, again, appreciate you joining today, and we'll be in touch with some additional opportunities soon. So thank you very much, everyone. Take care and have a great rest of your afternoon.
Thank you.